Aesthetic pocket reduction surgery for severe periodontitis in the maxillary anterior area. First of all, I'd like to thank Dr. Michael Sonick, who published this article in the most recent article of the compendium. And what he has done on this, he's given us a comprehensive review of the literature, precise surgical technique, incision design, and suturing, and above all else, a long-term post-op to let us know how effective this procedure is. Congratulations, Mike, on a very well done article. These are his criteria for doing periodontal surgery. First, to gain access for thorough root debridement. Second, for pocket elimination or at least pocket reduction, and regeneration of soft and hard tissues, and also to enhance aesthetics. And this is where we're talking about procedures for aesthetic crown exposure, also known as aesthetic crown lengthening, but I prefer the term crown exposure because we are not lengthening the crown. Before proceeding with Dr. Sonick's technique, which is conventional periodontal surgery, I do want to acknowledge that this type of lesion can be treated in other fashions. One of them is using the dental laser, which has become very popular in the last few years, or doing non-surgical treatment using the perioscope. And how do you approach this? In the anterior, you can approach surgery both buccally or palatally. And let's talk about the problem when we do the buccal approach. This creates overly long teeth, the healing is delayed, papilla are compromised, and if crowns are placed on these teeth and they're placed in the clavicular area, you're going to get further recession in the future. And this is what we see when we do the buccal approach. And certainly we see the overly long teeth. Obviously prosthetics is going to need to be done with crowns on all these teeth, and that's going to add significantly to the cost of the case. So if we can avoid doing crowns and stuff like this, we're going to be really way ahead of the game. The palatal approach, which is the basis of this video, means that aesthetics are maintained. It also allows access for the root debridement that we talked about earlier. And it prevents buccal attachment loss. And very importantly, it maintains the papilla. And here we see the palatal approach post-surgically, and then we see an 8-week post-op with a pocket elimination and the aesthetic result, which obviously is far better than the case we showed you just earlier. And one of the nice things that Dr. Sonick has done for us, he's given us a very thorough review of papilla retention techniques going back to 1967 and bringing us up to 2018. 2 thumbs up for Dr. Sonick. The palatal approach. And here we see what it looks like, and notice that the papilla have been maintained, but it has been flapped back, and we can see where the incision is made in the diagrammatic presentation on the right. And then we can see how this is undermined, and the tissue underneath that is undermined, as you can see on the right, is removed. And this is that tissue that is removed. And he uses in the palatal approach various burrs which can be used for root planing, smoothing, and so forth. And these are burrs that were developed by Dr. Sonick. And here we see the burrs being used here in this case for root debridement. Also, let's give him credit for all the burrs that he has developed, and these were developed by the Brasler Company. The palatal approach, degranulation. When do you use degranulation? In periodontal surgery, in debriding sockets to get good regeneration, ridge augmentation, certainly in implant procedures, and as we just saw, in using these burrs for root planing. So this is the degranulation burr that Dr. Sonick designed, and as I said earlier, it's made by the Brasler Company. The suturing technique. What we're doing here, and we can see that he is using a vertical mattress suture. This is one of his first cases when I think he's using silk there, and obviously in this day and age, we're not going to use silk. But anyway, we see below the day of surgery, and I think you can visualize how the aesthetics are going to be maintained. So let's summarize the suturing technique. Here we see the pre-op. We see where the basic incision is made. We can see where that tissue was removed, and then the palatal flap is folded in for pocket elimination using, as I said earlier, the vertical mattress suture. Now let's look at this 34-year-old female. Ladies and gentlemen, how about that for bone loss? How's that patient going to be treated in 2018 in the era of the all-on-4? Would you rather have these teeth maintained in health aesthetically for a number of years, or would you rather give up on them and go ahead and have an all-on-4 done? So look at how deep these pockets are, 8 and 10 millimeter pockets, and certainly a certain degree of mobility. But let's look at it from an MMPPI standpoint, the Miller-McIntyre Periodontal Prognostic Index. The age of the patient is 34. That is not significant. The patient's not diabetic, doesn't smoke. The molar type doesn't apply. And incidentally, this shows, although the original scoring technique in developing the index was based on molars only, here we see how it can be applied on single-rooted teeth. For those of you that are familiar with the MMPPI index, you'll remember that this applied for molars only. Let me give you a little background on that. When I started developing this, I was going to use all teeth. But when I started looking at it, the anterior teeth that I treated, I virtually never ever lost a tooth. So therefore, I decided to do it just on teeth that were much more susceptible to being lost, that being multi-rooted teeth or molars. But I think many of you who have practiced for many years realize that the prognosis on anterior teeth can be excellent if they are treated in depth. And that is what we did, and that is why we only scored molars in developing the technique. But I think these cases by Dr. Sonick graphically show that it can be used on single-rooted teeth as well. And if we look at this patient, as severe as that was, has a 93% chance of maintaining those teeth in health for 15 years, or an 80% in maintaining them in health for 30 years. Now let's look at post-treatment. We go in there, and with 8 and 10 millimeter pockets in the maxillary anterior, you may not get complete probing depth. You may end up with some 5 millimeter defects. So let's give it the benefit of the doubt and say we didn't get complete pocket elimination, but we did reduce that to a 1. And certainly the mobility, we were concerned about it, but we are less concerned now 15 years later. So we have improved the prognosis from a 93% to a 97%. But the significant thing is on this case is 15 years old, and now the prognosis is still 97% for 15 years going forward. But if we're going to get this level of success, we have to have complete patient cooperation. And if we're going to have this level of success, we've got to have keys to success. And these are the keys to success. The patient has to brush properly and clean interdental daily. They've got to clean the posterior third of the tongue. And there's a video on here that discusses that, because 90% of the bacteria left after brushing and flossing are on the posterior part of the tongue, and these are the sulfur-forming bacteria that are the main cause of halitosis or bad breath. Obviously, you got to complete the recommended treatment. You got to adhere to the recommended maintenance schedule. You've got to control the blood sugar if the patient is diabetic, and they got to stop smoking or at least cut back to under 5 a day. And for smoking counseling, we suggest that they contact 1-800-QUIT-NOW, where they can get smoking counseling 24/7, 365 days a year. In scoring with the MMPPI, we found that smoking was the most significant of all the factors evaluated. And what we found, we have 2 smokers with the same degree or level of periodontal disease. The smoker has a 247% greater chance of losing the teeth than the non-smoker. And when this information is shared with patients, this can be very impactful in convincing them to stop smoking. So here is his first case in 1986, and you can see the probing depths that he's got here, and you can see on the facial there are very few probing depths, but look at the probing depths between the central incisor. And here we see the bone loss and the probing depths and the surgery as we've already discussed, the suturing that was done, the vertical mattress suture, and yes, he did some minor orthodontics to squeeze the papilla, and incidentally, for every millimeter you squeeze the papilla together, the tip of the papilla will move incisally 1 millimeter. Now here we see the probing depth 15 years post-op. And ladies and gentlemen, would you rather have that, or would you rather have an all-on 4 that had been in there for 15 years? So here we see the pre-op, and then we see the post-op. Notice that the space between the central incisors has been closed by the minor orthodontics, and also by the healing that has taken place. So here we see the case in 2007, 2010, and 2015, which attests to the fact that the technique does work, and therefore you can go to the keys to success, and if the patient is willing to do their part, and you do the surgery as well as Dr. Sonick has done this, you too can produce this result. 1986, 2015. Now let's look at the MMPPI scores. We have gone down with deep pockets there, down to where we have a 5 scored on that, or a 93%. And one of the things that we found using the MMPPI is if we can keep the MMPPI below a 5, we can maintain teeth indefinitely and in health. So we use the little ditty. If you want to keep your teeth alive, keep your MMPPI below a 5. And yes, we've done that in this case. 15 years later, we have a case that has a better prognosis than it did 15 years before. So congratulations to Dr. Sonick on teaching us a technique that really works, holds up long term, and is a real service to patients, especially in this day where implants have become so dominant. Let's not forget that we can still save teeth.